Good morning. So welcome everybody. I'm Chorani from Assam Medical Center. My co-chair, Dr. Hutchison, and we have a distinguished panel here today. Dr. Bal, Dr. Capodano, Dr. Cha, Dr. Chan, Dr. Hong, Dr. Matsubura, Dr. Makamura, Dr. Sung Jung-bak, Dr. Santos, Dr. Tams. So let me start the symposium by live transmission from Assam Medical Center. Okay, Dr. An?
Yes.
Okay, would you introduce your team and case?
Okay. Thank you, Dr. John and Charan Lee. This is my fellow Dr. Do will assist me. I'd like to briefly, Dr. Do briefly introduce the patient clinical history. Could you please?
Yes. This 66-year-old male patient was admitted for the evaluation of coronary artery disease. Actually, he was diagnosed as cerebral coronary artery disease with unstable angina at the other hospital, but he was refused to receive. At that time, he recommended CABG, but he refused to CABG. And recently, he felt aggravating for chest pain about 1 month ago. Coronary angiography for unstable angina showed cerebral disease and left main disease. RCA lesion was CTO, was treated with PCI with 4DS, and stage revascularization was planned for the left side lesion. And the syntax score was 37. He has risk factor as diabetes, hypertension, and ex-smoker. His clinical presentation was unstable angina. The echocardiography showed normal LV systolic function without the regional wall motion abnormality. We didn't check any other stress test.
Did you see the coronary angiogram on the screen?
Yes, we can see clearly.
Yes. Could you show us the RCA? Okay. Good. Could you show us the simultaneous RCA and left side on the screen?
So 1 month ago, RCA was the culprit or left main culprit?
Actually, we didn't know. So, please RCA. Pre-RCA, please. Yes, this is RCA. And proximal peritonitis stenosis. And distal CTO lesion. And left side. Yes, this is the left side. Today I checked the left side coronary angiogram. Look at this. Very huge ruptures on distal left main and CTO at distal circumflex. And the circumflex ostial disease status we didn't know yet. And diagonal, proximal diagonal, big diagonal disease, and proximal AAD disease. But fortunately, this disease is confined to the proximal AAD, proximal diagonal. This runoff is good. So Dr. Do already mentioned that this patient have had symptoms for 3 years. At that time, the attending doctors recommended him to have bypass surgery, but he refused bypass surgery, and then for symptom control, every day he received the nitroglycerin. So he cannot, because of severe chest pain, he admitted my hospital, still refused surgery. So first of all, I'd like to discuss with is he a good candidate for PCI? And I'd like to some comment on patient history and coronary angiogram.
Well, this is a very interesting case, and I think clearly the recommendation for bypass surgery was appropriate. Given the fairly complex nature of this, you've got a CTO in the distal circ, you've got a CTO in the right, you've got complex left main diagonal LAD disease with very nice distal targets. So I think the recommendation for bypass was appropriate, and I'm just curious why this relatively young patient is so against having bypass surgery.
Many Asian people, Korean patients, don't like to have a bypass surgery.
This is
So this is a
patient
common
preference. Patient don't want the surgery, so.
Yeah, no, I understand, but sometimes you have to be more persuasive.
To be honest, the doctors want a PCI. Right.
So could you show us the final ICA? So initially I planned that, yes, bypass surgery is the first option, no doubt it. But patients don't like it. So if my initial plan is if ICA CTO intervention failed using integrated approach, I have to transfer patient to the surgery. But fortunately, we success to RCA CTO intervention with the stent. So RCA is perfectly corrected, and then remaining left main and LAD big diagonal disease, I prepared for live demonstration. So RCA is a normal flow, and only left main proximal diagonal disease left. In this situation, I think the bypass surgery is not necessary in this case.
Dr. Hutchison, do you use a syntax squat to guide the left main revascularization strategy?
Well, we do, but I think in the United States, I think the penetration of left main intervention is still relatively low compared to Asia. So a patient like this, we would try very hard to have them go to bypass surgery. And you're planning then to leave the distal circumflex occlusion and not try to treat that?
Yes, I don't touch the distal circumflex occlusion.
Okay.
If I successful to the left main stenting, only distal circumflex one vessel disease remained. I think I can manage his distal left main one distal circumflex one vessel disease could be managed by medical treatment.
So what is your planned approach here for this left main LAD diagonal?
So traditionally, we prefer the femoral approach with the 8 French and jockeying guiding catheters, jockeying left guiding catheters. And then for the distal left main bifurcation treatment, the most important thing is circumflex ostium evaluation by IVUS, not angiogram. Angiogram, there is some overlap, so we can see clearly the circumflex ostial disease status. So initially, I insert wire to the circumflex. Next. And then I evaluate IVUS first. Could you show us the circumflex IVUS? Okay, long please. Vessel is very huge, almost 4 orbits circumflex. This probe is coming to the more proximal and proximal. Small side branch is coming, and minimal plaque. Here is left main. Stop, please. Can you show us the ostium of circumflex? Okay, here. This is ostium of circumflex. Very minimal plaque. Minimal lumen is very huge. So in this case, we don't need to stent procedure for this particular case. So I decided just a simple crossover for left main bifurcation. So I pulled out wire, and then to evaluate the diagonal and LAD, I insert 2 wire, BMW wire to diagonal and BMW wire to LAD. And then evaluate sequentially diagonal first, and then LAD.
IVUS.
Could you show us IVUS, please?
Okay.
So this is a diagonal. Diagonal is a very big,
Big one, right?
more than 3.0. Minimal plaque,
Almost 3.5.
yes, more,
Minimal
almost
disease.
3.5. Yeah.
Distally. Okay, still big one. Normal looking areas between superficial calcium.
Here is a
Whoa.
proximal
Awesome.
diagonal,
Ostium involved.
Yeah, pretty
and
much
here is
black.
ostium diagonal branch.
Okay.
Here is left LAD, and stop. Could you show us the LAD pullback, please? LAD is very big as well. The most important things, the distal stent landing zone.
This is interesting. Circumvessel big, the territory very small, and diagonal territory is bigger than circumference.
I
Long,
think the
this is
distal
the proximal
circumference is probably
AD.
bigger than it looks. The
If you
occluded-
open it,
the occluded
LAD
distal
is
circumference
more
probably
than
bigger than it
4.0,
looks. Distal right is
4.5.
relatively
Here
small.
is calculate, very tight stenosis, some superficial calcification.
That's in the mid.
Plaque is
LAD.
mostly soft plaque, and superficial calcification at 7 to 9 o'clock. Some calcification, but not severe calcification, so I think it is very delatable. The diagonal branch wire is coming in. You can see
rupture.
stop.
Dissection,
Yes,
the
rupture,
9
plaque
o'clock?
rupture, huge plaque rupture.
ruptures, right?
Yes.
Big ruptures.
And then run, please.
so maybe this is the culprit
This
for
is a
one month of-
circumflex ostium is 5 o'clock, and this is left main superficial calcification. Left main is very huge. Inner lumen diameter is 4.0.
disease?
Vessel diameter is, I think, more than 5. Some disease.
So I think this
a
is an
rupture.
interesting display, considering the lecture you just gave. Did you have any consideration of doing FFR across this? Because the lumen area is quite big, despite the rupture, which is now at least a month old.
So, but this patient, the unstable manifestation, and then the culprit, I think the LAD is very tight and diagonal is very tight. I think FFR is not necessary. I do my procedure without functional evaluation. So,
The
my
fluoroscopic calcification is not always matched with the plaque calcification itself. However, in this particular cases, anyway, there are pretty amount of superficial calcium too. So, why would you do that? The diagonal branches, big diagonal hyper disease and proximal disease, distal limb main disease, and so. What is your plan?
So what's your plan for this diagonal and LAD bifurcation? Do the diagonal first and crush it, or what are you planning there?
Yes, my plan is diagonal crush. We prefer the crush technique to treat the bifurcation disease. So I like for the diagonal stent first and crush by balloon, and then implant LAD stent, and then rewire and final kissing balloon.
Okay.
This is my plan.
Were you able to measure the length from the IVUS for that LAD to the left main? How long would that be?
Yes, could you measure the length from the diagonal lesion and LAD lesion? Previously, we already measured the length. Diagonal branch is 15, and LAD to left main is 32.
32. So
Yes.
you wanna do kind of a stent crossover from the LAD to the ostial main, right?
Yes, right.
Okay. So balloon crush first and the diagonal branches, and then a long deregulating stent from LAD to the main. And
Yes, that's
we
right.
didn't prepare guide wires, even guide wire for circumflex ostium. The reason why circumflex ostium is free of disease, we have some clear confidence. Is,
That's why I removed the circumflex
okay,
wire.
Not too much compromised in the after the stent crossover. Okay, go ahead.
So if I correctly
Okay, give me the 3.25 18 millimeters stent.
So if
That's a
I
great
correctly
size, I
understand you, Dr. An, so you would apply two-stent strategy from the beginning, and you would
Yeah.
use the mini-cross technique. Is
Yes.
that correct?
Yes, mini cross
Then
technique.
finish with kissing balloon dilatations. And then
Yes.
the question is, another question is, would you stand all the way to the to cover the left main ostium as well? Or?
This is 18, 3.25 based on the IVUS. So I insert IVUS without pre-dilatation. I insert the stent without pre-dilatation. And then please for all high pressure balloon for LAD.
Is it non-compliant?
Yes, non-compliant for all 20 high pressure balloon.
So you are going to balloon crushing.
Yes, balloon crossing. Sometimes this is convenient. Okay, here. Test, please. Okay. I'd like to see the distal diagonal. Test, please. Okay. This is my expected distal landing zone. I'm very happy. And then turn to the spider view.
Okay, that's good.
Yeah. Inflation, please. Circumflex.
Diagonal.
Diagonal, please. 10.
10.
What size of stent? 3.0?
3.25.
I think that's a great size. Yeah.
3.25.
Depilation.
What type of stent?
Giant
Giant.
stent.
Right. Yep.
Yes. This is the most important step.
And,
Before removal the circumflex wire and balloon, we have to inflate as big as you can for dilatation of side branch ostium. So inflation. We already knew side branch ostium more than 3.5, 10, 12,
12,
13,
13,
14.
14.
So the nice thing about the
16?
balloon on the Zion stent is it is
Yes.
semi-compliant, and you can go up by
Yes.
about a quarter size. So
Depilation. This step facilitated the easier recross rewiring. So I like to remove a whole system for side branch. And then please inflate LAD. Inflation. This is for all balloon.
12.
Depilation. Depilation.
It's a little bit. All right.
For all.
Yeah.
Push the
Yes,
balloon
for
inside.
all
and
balloon.
Came back
very
a little
great.
bit.
All
There
right.
you go.
Okay.
Here, there.
Inflation.
Is this a non-compliant for balloon?
Deflation. Some splicing.
Wait, okay.
Slowly. Inflation. Slowly. Okay. Slowly. 12. 14.
14,
16.
16.
LED region is also some, calcified. The
So
reason why.
facilitated the LAD stent delivery. This is kind of region pre-modification. Inflation. 16.
16.
Depilation. Okay. So, remove a balloon.
Hemodynamic is okay?
Yes. Patient no symptom. Vital sign is very stable. Let's check the coronary. Ready?
Ready?
Good.
Yes, I am very happy. Side branch flow is perfect. So, could you give us 33 millimeter length and 4 all giant stent, 4 LAD to left main, crossover.
Very complex, visually complex region subset. If we have a, simple procedural strategy, I think the procedure itself is, we can make a more simple, right? So,
Test, please.
well, what length?
33.
33.
Test, please.
It's relatively
Okay,
short.
here. Test, please.
33, 38, what's difference?
Good. Yeah, I know, but 33, I think the pre-lesion planning, I think 33 is enough. Test.
So,
Okay, this is my distal landing.
what
and
do you think
proximal
a
landing.
distal part of a
Want to
stent?
go a little bit more distal and
Based on
please?
IVUS, distal
little bit
test.
haziness. So
yeah, I think you want to land closer to that septal.
What about the 38?
If you've got enough length
yeah.
proximal still, yeah.
But the distal is a very diffused, mildly diffused plaque, so I think 33 would be good. So if something happened, I put the one more stent.
Okay.
Another test, please. Okay, go.
10.
10, please. Okay. Depilation. I know proximal AD diameter is more than 4, vessel diameter more than 4 hole. So I implantation high pressure, 16, 18,
18,
20.
20.
Balloon diameter,
Implantation,
final,
4.4.
4.4. Semi-compliant delivery balloon can make a bigger balloon, high pressure inflation, bigger balloon diameters in the finally.
So test, please. Okay. So ready? Nitro, please. Okay. Ready?
Good.
Okay. So before side range rewiring, I like to check LAD stent optimization. So please, IVUS, please. After LAD stent optimization, and then I try to do side range rewiring, and then rewiring successful, I apply the final kissing balloon.
Doctor, would you show us spider view
Okay.
shot? Just confirm about the circumflex ostium and diagonal stented side too.
Ready?
Yeah.
Great.
Very nice.
yeah,
All right.
left main probably with additional dilation.
So I would consider proximal optimization anyway, even without IVUS, because according to the law of bifurcations, if you have a distal main of 4 and a side of 3.25, you may expect a left main of 4.5.
Here is
Or
distal
even 5.
landing. Here is the
huge
distal
vessel.
landing. So huge
Vessel.
vessel,
It's occurring
mild plaque.
superficial calcium.
Here is
And
endogenous
here
stent.
is the distal landing.
Perfect. Right. Distal landing is
Based on
good.
IVUS, I can decide clearly distal landing zone. So a little bit underexpanded compared to the vessel size. Lumen is quite big, but compared to the vessel size, proximal LAD a little bit small. So the proximal LAD and side branch is coming from 5 o'clock, very proximal LAD. And circumflex is coming from 5 o'clock. Here is the distal end main. distal left main stent expansion is very good.
Some, 11, 12 o'clock's part of a malacuminal position.
Yes.
However, mainly depending on calcium and vessel size. 4, 3, 5, 4. Okay, good.
Okay, could you measure prox LAD vessel size and stent?
So I'm a little surprised that it's not malopposed in that left main, but it looks pretty good.
Some
Vessel
portion
size is
of rupture site.
Yeah, some portion, because of ruptures, some portion malopposed. So I applied a more bigger balloon for LAD, prox LAD, and left main. Please give us almost 5 or high pressure.
Dr. Ang, you use a 4.0 stent for the left main. It's a science stent, is it? It's a science stent, is it?
Giant stent, yeah.
So what is the maximum stent diameter you can achieve in science 4.0? Is it able to achieve 5.0?
Yes, 5.0 we can achieve.
Okay.
This is a 5.015 high pressure balloon.
Dr. Capodanno's, Dr. Capodanno, can you hear me? Capodanno,
please.
David? Okay. For particular these cases, all right, look at that. Syntax score is more than 30 something, right? Very high syntax score. And issue is, if we have a good ideas, we can manage is perfectly, good. That is quite similar with the bypass surgery in terms of the main, right? And so if you look at some data in the syntax score work, more multivessel disease, however, main disease, even bypass surgery, the PCI doesn't work too much, right? The reason why immediately after drug stent is not a big problem in terms of angiographic, stratification. So
13, 14,
the reason why,
15, 18.
the predictive power is only
Deflation.
angiographic complex stage, not too much work. That is why.
Yeah, and I have to say that the syntax score doesn't include the patient preference in the algorithm. And in this case, it played a huge weight, I mean.
18. So stent getting bigger, deflation. In this kind of big vessel, even though we put the bare metal stent, the restenosis rate, I think, very low. Much bigger than before. And then I like to take an angiogram. So, okay.
Oh, Dr. Han,
What do
very
you
nice
think about
result. So, in the meantime, we have to go to another room and we'll come back soon.
Okay.
So, go ahead.
Okay, thank you.
Okay, Dr. Sess, can you hear me?
Yes,
left
I can hear.
upper. Left upper is seen.
Okay. Deflate. Yeah, hi.
Okay.
How are you guys?
Good morning.
Good morning to you. We've had a bit of a hiccup related to the fact that the lab in which we started off broke down, so we actually moved to this lab. And so it's a great pleasure to be here with you all. And it's my privilege. Thank you, SJ and team TCTAP for inviting me to actually do a live case at this great labs of Asan Medical Center. Now, with me is Dr. Lee, the director of the lab, so I'm privileged to be working with him as well. And then Dr. Kwan, who's a fellow in interventional cardiology. So Dr. Kwan, why don't you tell them about the case?
Sure, yeah, let me tell the case. The patient is a 59-year-old male, was admitted for the approach chest pain. About 9 years ago, he was performed PCI at distal left main to proximal LAD and proximal circ with a crush technique. 1 year later from that, he underwent POBA for proximal circ ISR. The current angiogram at this time showed the proximal LAD distal edge ISR and circ ostium ISR. As I said, he had a PCI history with the CYPER, and then 1 year later, Cirque had a POVA. Next. He had a diabetic and hyperlipidemia, and also he had a liver transplantation history. So at this time, he presented with a stable angina, and the syntax score was 11. Next. Echocardiography showed apical septal hypokinesia with normal LV systolic function, which was not changed, and the thallium SPECT showed the reversible defect at LAD. So the coronary angiogram left side showed the focal stenosis, ISR involving the distal edge of the proximal LAD stent and the ostium of Cirque. The right coronary angiogram showed focal mild stenosis of proximal right coronary artery. Next.
This looks good. I just wanted to see the lesion, what we've done to it. Yeah, I'll take a 3.5. So here's the discussions around this case. You saw that there's a circumflex ostial stenosis. You saw there's a high-grade LAD stenosis, and these are not restenotic lesions. We're now 8 months post. So there's a new lesion, and so certainly this could be a new atherosclerosis on that in that ostial circumflex. So we leave that open for discussion. An interesting case in a person who's had a liver transplant.
So Ashok, these are actually 8 years post, is that correct?
8 years post the second intervention, and 9 years post the plantations of the ciphers. I must also say that was a crush technique, which was done on the cipher, the distal left main bifurcation.
So what is your strategy here?
Okay, so here's the strategy which I had in mind. The circumflex lesion doesn't look high grade, at least on the angiographic images. So there's no doubt that what one wants to do is image it as well as do a functional assessment of the circumflex. If the circumflex lesion is non-significant, and that's suggested by the fact that the nuclear scan only showed an LAD territory ischemia, anterior ischemia, then one would just attend to the LAD lesion. When we attend to the LAD lesion, we want to image it, want to have the optimal sizing. And the reason we want to do this under IVUS guidance is the fact that 2 choices come in. This is a patient who don't want to give prolonged dual antiplatelet therapy, or at least want to limit dual antiplatelet therapy to the least minimum possible. And that would be possible by actually either, arguably selecting the right stent, which could be perhaps with a biodegradable polymer. And also, if we do a good IVUS-guided stenting, then again it helps us to take him off a DAPT earlier if it was necessary. And when I say earlier, I'm looking at even the possibility of 3 months of dual antiplatelet therapy, maybe 6 months, but no longer than that.
So Ashok, from here it looks like the LAD stenosis is distal to the stent. Perhaps, can you share if it looks that way there, or do you think that it's also in-stent?
So have a look. There is a distal in-stent. Atherosclerotic plaque starts from distal stent. And let's look at all the views. So let's have the next image, please. And here, here also you don't get that next.
Yeah, it looks like the bulk of it is outside of the stent.
Yeah, the bulk of it is outside. The highest grade is outside, but it starts extending from the distal 5 or 7 millimeters. The ariocaudal projection probably shows it much better. Let's go to the ariocaudal, and you can see that. Can you see the stent? Yes. The stent is just beyond, at least 3-4 millimeters beyond that little diagonal which comes, but the tapering starts from the diagonal itself.
So it certainly supports your hypothesis that this is a de novo lesion.
Correct.
And opens up, obviously, the easiest way to treat this is to put another stent there.
Yes, and that's the reason why we felt that a stent is the best option rather than drug-eluting balloons and so on. The second aspect is it's a large vessel. And this sort of a new lesion, one would not rely on just a drug-eluting balloon. That would have been a consideration for circumflex ostium, and certainly had that actually showed up on the FFR as an insignificant lesion. So should we then show you what the imaging showed?
Right, I think that the Cirque FFR is going to be very interesting. It's a very big vessel.
Yes.
Goes all the way to the apex there, so.
You're right. You're right, John. So let's show you the FFR. And well, I mean, we may not have the images of FFR, but it's very easy to tell you that it was like 0.95. Oh, there it shows you, 0.93.
Yeah.
It sort of comes up on the monitor. So that was on an infusion. So and let's show you the image also.
Where I was?
So that was the peak dose of infusion, and now the IVUS.
Yeah.
And the IVUS images weren't bad either. It did show soft plaque. I mean, I think it's a neoatherosclerosis.
So this is in the circ now.
It's in the circ. You have a big vessel there.
Some expansion is
That
good.
stent looks great.
And the stent is expanded beautifully. Just shows that this was IVUS-guided stented. Yeah.
Lumen area is almost a 3.
That's probably going to be around 4 square millimeters, you think? Did you measure that?
Match it with the negative FFR. So
3.7.
3.66.
all right, that's quite enough.
Yeah, it's quite enough. And the FFR was 0.93. So we decided that was good assessment of that lesion, and we progressed to the LAD.
Good.
Now, so let's have the LAD visualization, the IVUS on the LAD.
IVUS, please.
IVUS.
Yeah, and here it comes. So again, a large vessel.
A big one. 3540.
Yes, that's right. At least 3.5 to 3.75. And that's the area of maximum obstruction soon. There's a lot of plaque there, and some calcification. That's right.
Right.
And so this is the highest grade area. 90-degree calcification, yes.
Got at least 90 degrees of a normal wall there, and then a very eccentric calcified or highly attenuated plaque.
Right.
There's the
And
stent
that's
there.
the stent. I felt that the distal edge of the stent was slightly less expanded. Now we see a bigger lumen. So I think that
Yeah, the stent's at least 3.5, 3.7 there.
yes, 3.5.
And there's the left vein there.
Yeah, we just now move to the left vein. So we have now the situation of, so here's how we decided to proceed. Unless you want to discuss.
So only focal stent?
So we protect, we have a look at the measurements of the IVUS run. Yeah, fairly large vessel. Any comments on that? No, we've decided that what we need to do is say the measurements we got, and we'll just assess those, is the fact that a normal to normal media was approximately 22, 23 millimeters, which would mean a 24 stent. I guess that means that we actually come down the vessel, that you see the diagonal, and then you see the vessel beyond the diagonal. Clearly a 3.5 millimeter stent, and then expanded subsequently with high pressure dilatations. And the third aspect of it is that if you see in the LAO-caudal projection, which is the LAO-caudal coming to you now?
Yes.
And you see that the diagonal.
Do you want to protect the diagonal?
Absolutely. I want to protect the diagonal, and as long as it remains patent at the end of the procedure, that's all we want. It's a reasonably large diagonal, but not enough to chase it, apart from making sure it doesn't go down. So we decided to actually pre-dilate the lesion, and because of that arc of calcification that we saw, we said, let's take a scoring balloon and and do a good job with a 3 millimeter scoring balloon. We went up to 12 atmospheres, and that's when we sort of started transmitting to you. Okay. I'm sure we could have gone up more. This is showing you the scoring balloon, and it's expanded. We could have gone up to high pressures, but as we sort of came on, we deflated the balloon. Okay. So we're on now to go to implantation of the stent, and I'm not very happy with this view. It doesn't show you the proximal very clearly. So I'm going to go to areocaudal view, take a shot, and then see how we can place the proximal edge of the stent. The distal, of course, we can always place that. So we'll go to areocaudal view. And in the meantime, you can continue to discuss.
What stent would you use to treat this lesion as well?
Okay, so we've chosen Synergy here, though I have in any, yeah, let's go.
Okay, I'm sorry.
Good. So so I've taken Synergy here. Well, yeah, let's take it. Good. So we would take a 24, and the discussion about Synergy versus anything else, well, we decided in a way that we would actually take a stent which was give us at least some theoretical advantages. And the theoretical advantages could come from the bioresorbable polymer, should we say, maybe the ability to stop if dual antiplatelet therapy earlier if the need arose. And I guess most of the good, in fact, the present generation of stents, even the fluoropolymer on the Zynes, would allow us to do that in a large vessel with IVUS guidance at an early stage. But we've chosen Synergy. And we would take it seems that we would take a 24. Would you? Lee, you agree with the 24?
Yeah.
So we're going to take a 24, implant it from that diagonal onwards, and see how the result looks. Okay.
So you're choosing a 3.5 diameter?
Yes, 3.5 into 24.
Okay.
But I'm going to be cautious on not going on high pressure with the balloon. I'm going to go up high pressure with a non-compliant balloon.
So if you prefer to use a shorter duration of DAPT, would you consider a biofreedom stent which will allow you to just give 1 month DAPT?
We must remember two aspects. We prefer a shorter duration, not because there is a contraindication to a dual antiplatelet therapy, but the fact that he's a liver transplant patient may bring up such situations which require it. Had this patient been a bleeder of some sort, had this patient required a liver transplantation in the next couple of months, that's when it would have become a good choice. All said and done, we've got to keep in mind that the efficacy of biofreedom is not the same as these fully. So it's an advantageous stent, but not a replacement for drug-eluting stents in those situations, which can actually have a good second generation or current generation drug-eluting stent. Okay, and yes, let's take an image. Test check. So we're going to start from here. Again, imaging.
Image.
Yeah, good. I'm happy to start here, but let's go to the cranial view also.
So you've got quite a bit of overlap there.
Yeah, but remember we will adjust the overlap first. I'm going to see what it is distally, and yeah, that looks good. Okay. So let's let's come back to the areocaudal, because that's where we want to actually make sure that we have an overlap which is not huge, but takes into account what we've actually decided. So here the guiding goes in properly, so that we have less of a movement. Can we just take an injection?
Take a picture.
So here we go, here.
Okay.
And can we take an injection here?
Yeah.
No, see, okay. And again, injection.
Okay.
Yeah, let's go up. 6, 8.
6, 8, 10.
10. So we got it's 10. And I always tend to keep it up for a bit. You know, this is always a good idea that you keep it up for 10, 15 seconds and then deflate.
Second.
Deflate?
Is this Onyx?
No, this is Synergy.
Synergy.
So you know the factor that stents expand better either on a couple of sequential inflations or keeping them up for 15 to 20 seconds, and that's when you get the full expansion of stents, and that goes same for any stent and scaffold.
Ashok, I'm not in disagreement with you, but the only hard data that we have based on randomized clinical study for patients with high risk of bleeding is from leaders free trial using biometrics. We can discontinue the TAP dual antiplatelet medications for 1 month safely.
So here is a situation. Yeah, you're absolutely right. So you are agreeing with me or disagreeing with me?
No, I agree with you, but I just want to mention that the only hard data based on randomized clinical study so far is just comes from Biofreedom.
Sure. And I'm not even thinking of a 1 month. Remember, he's not a bleeder. He's not bleeding. He's just in a category which can bleed or may require discontinuation of a dual antiplatelet therapy early.
Okay. Go.
So why are you imaging before your post-dilatation?
Just to get an idea as to what will happen after. These are always good learning experiences. I'm going to do a post-dilatation, but let's see what 10 has done. What's the sizing? And definitely going to go with a high pressure to 1820. And let's see the differences between a 10 atmosphere implantation, which got us a 3.6 or 3.65, versus what we do with post-dilatation. And you can see how undersized this is.
Yeah, distal landing is good. Still, at least minimal stent area is more than 5. It's good. 6.
So I think it is a good learning point. If you've noticed all the cases at this meeting, high pressure is 18, 20, more than 20.
You can see that this is an asymmetrical expansion here.
Yeah, which you'll probably never get rid of.
But we'll see. I think this is why I want to do this and then do it afterwards. And we just got a diameter of 3 around here. So I think we got a lot more to do on this on this stent.
And many investigators, or operators, not investigators, but operators, use 14 atmospheres, maybe 15. They consider that high pressure. It's not.
Angiographically, the result looks not bad. So let's now get on to high pressure dilatations.
Okay. I know stent area is good compared to the vessel diameter. It's still, stent diameter is under expansion. Area is good, and so.
So what's your choice for the post-dilatation balloon here?
At the moment, it's a 3.5, but we'd go up to 20 atmospheres. We would remember that we could even go up to a 3.75 or 4 after our IVUS assessment. But this would be going up real high pressures now. Can I just take a cine and be sure of this?
Yeah. It's okay.
Yeah, it's okay. Let's go up. Yeah.
12, nominal, 12.
14, 16,
14, 16,
18.
18.
So how much? This is 3.5?
Yeah.
Non-compliant? 20.
20.
Good. 3.7, and we take a cine and keep it up and deflate. That was a 12 millimeter?
20.
15.
Okay. 15. Go up again.
Go.
6,
20.
10, 20.
20.
So we're going to keep it up at 20 atmospheres. And the reason don't deflate it. I again keep it up for at least 10 to 15 seconds. Okay. Deflate. And then my most proximal. And the other reason I overlap this is again for the same reason that let's Okay, I think we are there. Let's go up.
Okay.
10, 12, 14, 16,
20.
20.
20.
Great.
Good. Okay, deflate. So let's now have a look.
Okay.
First an angiographic look, and then let's have an angiographic look.
Angiography.
Okay, ready?
Yeah.
Okay. Okay.
Beautiful.
Good.
So Ashok,
And
I
now
agree
we'll-
with you that the duration of inflation, helps. And
Yeah.
you can tell this if you watch the inflation dial, it'll gradually drift down, and that's a sign that the stent is expanding. So keeping
Yeah.
it up for 20, 30 seconds, I think, is the correct way to go.
Yeah. And small studies have demonstrated that. I mean, not that anybody is going to do more and more studies on this aspect, but this is common sense as well as been demonstrated in a number of small studies. Repeat inflations, three times, or prolonged inflation.
Take some time for the fibrous tissue and the calcified tissue to stretch and to tear apart.
Yep.
So you always wait 20 and 30
Yes,
seconds.
always wait 20 or 30 seconds.
It's a long time. 30 seconds.
Yeah. We've got so impatient these days that everything seems to be long, isn't it? We really, some of the stuff that we do as being impatient is what relates to substandard techniques, and perhaps not as great TLRs as we would even expect with these generation stents. So when we say have these stents actually flattened out, I don't think the stents may have flattened out, but our techniques have become shoddier and still need, we need to go backwards and do a proper jobs like this.
Ooh, getting bigger, much.
Yeah, some of us are old enough to remember just balloon angioplasty, where we would leave the balloon up for 2 or 3 minutes to get a good result. That does seem like a long time, but
Downward branches.
Yeah, side branch tonight. So here you see
still
that
oval
calcified area,
Yeah.
it's opened up. It's now more uniformly circumferential at that calcified area. And within the stent also, if we look at a big area,
I think it looks much better.
Big enough. Stent diameter is more than 3 and 3.5.
Okay.
Here.
Yeah.
This is the left main.
so personally I think that we've done, I don't think we did a 20 atmospheres, I don't think we need to go to the 3.75. What do you think?
I agree. I think it looks fine.
Okay, I'm going to go to the AP cranial projection as well and take a shot in that. We want to make sure that the diagonal is well preserved. We want to see the distal edge as well, and we saw that on the IVUS, that the distal edge didn't show any dissections, and that looks really expanded.
Okay, it's good.
So personally, I think that we've done our job, unless anybody else feels differently.
Any comments from the panel?
Okay.
And the diagonal is well preserved. So we have a step up, we have a step down.
Dr. Seth, this is Kim Ming Tian from Hong Kong. Would you consider OCT as the imaging modality in this case? Would there be any advantages over IVUS?
Personally, I don't think there's any advantages. There's so much data on stent implantation and IVUS for us to be able to understand optimal metallic stent implanter. Now, I would actually, have a different view if I was doing a BVS, and I rely on OCT far greater than I do on IVUS for BVS. The visualization of a BVS struts on OCT examination gives us the comfort that we've embedded them properly, which I don't get from IVUS visualizations.
Thank you.
Okay, Dr. says you got already
So
very
we're
nice
taking-
result.
Yeah, I'm taking the diagonal wire out. Thank you.
Okay, thank you very much.
Making sure that doesn't go in. And we have
Thank you very much.
So we'll
Dr.
just go
An?
back to Dr. An.
Yes. I'm waiting to show my final result. Before showing my final result, I will tell you what we've done. So this is the final shot you've seen. Next, I tried to insert rewiring, several failure, and then next, I'm a success to insert the side branch wire, and next, I insert the 2.5 balloon side branch opening, ostium opening, and then remover, and then I insert the high pressure 3.5 20 balloon. Inflation, side branch, and then side branch inflation, and then high pressure up to 20. This is a final kissing balloon. Side branch, diagonal branch 3.5. LAD for all 20 balloon up to 12 atmosphere. LAD and left main is very big, so I can increase the balloon size up to, increase the atmosphere up to 12 something. I remove the 2 balloon. So I already removed the 2 wire. I'd like to show you my final coronary angiogram.
Perfect, perfect.
Very nice.
Right. Very nice, right? Circumflex ostium is perfect. There isn't, we got ideas by Ives finding ostial circumflex is pretty free of disease. So we don't care about during the procedure. And just diagonal and LAD and main crush technique can make a almost perfect result here. Okay.
It's very nice crushing.
Okay. Very complex left main peripheral vessel disease. I modified the complexity of patient coronary artery disease from severe left main plus peripheral vessel disease to distal circumflex one vessel disease. I think distal circumflex one vessel disease can be treated by the medical treatment only. This is my message I want to send.
Great.
Very nice job.
May I ask
Thank you.
question,
very nice.
Dr. An?
Okay, thank you very much. Thank you very much.
Thank you. Thank you very
you.
much, audience and chairman.
Okay, thank you very much. Let's move on to next sessions, when and how to do PCI. The first speaker is Dr. Nico Fields. He's going to talk about FFR-guided PCI can make better outcomes.
Thank you, Mr. Chairman. Ladies and gentlemen, it is a pleasure to give this presentation. These are my potential conflicts of interest. Let's first conclude that from a patient point of view, the wind tunnel for any index to be used in clinical medicine is its influence on outcome. And if we are talking about FFR and clinical outcome, there are in fact 3 important questions. Is it safe to defer PCI if FFR is negative? Is it indicated to perform PCI if FFR is positive? And does systematic use of FFR improve outcome of PCI? The first question can be answered by the DEFER study, which tested the safety of deferring PCI of non-ischemic stenosis. The DEFER trial were patients with single vessel disease and an intermediate lesion. These patients were randomized either to deferral of PCI or performance, and thereafter the FFR measurement was done. We did that in that time because we wanted to avoid that doctors, based upon the FFR result, would not include patients in the study. If the patient had an FFR below 0.75 at that time, he was stented anyway, but if the FFR was above 0.75, there was the randomization either to defer or perform of the procedure. After 5 years, the MACE rate in the defer group was less than in the perform group, although not significantly, and there was no excess of complaints in the patients who were deferred. We have now the 15-year follow-up of the deferred study, and it proves that in the patients who are deferred with an FFR negative lesion do significantly better than those who had a stent. There was significantly less late infarctions. You see that here, and all these late infarctions in the perform group were related to the target artery. So from the deferred study, we can conclude that after 15 years, there is no difference in mortality, but the late infarction rate is a significant advantage in favor of the deferred group, and there were no differences in repeated revascularization. And this is not so new and unique, in fact. We know also from the FAME studies that if you defer a lesion, which is FFR negative, that the infarct rate and the mortality is only less than 0.5% per year. And also with other studies of investigations, with CCTA or with IVUS, the prospect study, we know that if you have a non-significant lesion, that is safe to defer. The second point, is it indicated to perform PCI if FFR is positive? That is a FAME2 study, including all types of coronary artery disease with FFR measurement and all target lesions. When FFR was negative, non-ischemic, in all lesions, we defined this as a control group. And in the patients who had at least one stenosis with a positive FFR, with an ischemic stenosis, there was a randomization to perform PCI or just optimal medical treatment. And the follow-up was up to 5 years. So in fact, we divided the patients into two groups, the good guys who did not have ischemia and the bad guys who had ischemia and at least one stenosis. And this was the randomized trial. And if we look then at the outcome, in the first place, in the patients without ischemia, with all negative FFR, you see that the outcome is excellent, a very low event rate. If you look at the patients who had ischemia in at least one lesion and who were treated by medical treatment, there is a much higher event rate. But if you take these same patients and you put a stent in it, so you treat them by PCI, you reduce the event rate significantly, and in fact it is not different anymore from those patients without ischemia. So it is very clear that if your FFR is positive, you do a lot of benefit for the patient by stenting. And even if you look at DES and MI, in a landmark analysis, there was a significant advantage of placing a stent in an ischemic lesion compared to medical treatment. The third question, does systematic use of FFR improve outcome of PCI? That is a FAME study, with the hypothesis that FFR-guided PCI is superior in multivessel disease to angio-guided PCI. In the FAME study, patients with multivessel disease were brought to the cath lab. The operator had to indicate all lesions he considered for stenting, and then the randomization was performed. Either angio-guided, which meant stenting of all indicated lesions, or FFR guidance, which meant measurement of FFR on all lesions and only stenting those with a positive FFR, follow-up to 5 years. And what we found was that all types of event, not only MACE, but also DES and MI, was decreased by 30% in the FFR-guided group. And these good results were maintained over a period of 5 years. What about left main? There are 3 prospective studies, 8 registries, about 800 patients together. Important, not a single patient in any of these studies ever died due to a deferred left main lesion with an FFR above 0.80. And if we look at the largest study by Hamilos and Müller, we see that the survival rate is completely identical in patients with a deferred CABG with FFR more than 0.80 compared with patients with CABG and an FFR of less than 0.80. So also in left main, and we prove the same for RAD, using FFR to define if you need an intervention or not is very useful. So our 3 important questions can all be answered positively. It is safe to defer PCI if FFR is negative. It is indicated to perform PCI if FFR is positive, and systematic use of FFR improves outcome of PCI considerably. What about outcome of FFR-guided PCI in acute coronary syndromes? We have recently seen 2 studies, the Compare Acute and the Primulti study. One of them performing primary PCI immediately followed by FFR-guided PCI of the remaining lesions, and the other one followed by FFR-guided PCI of the remaining lesions within the same hospital admission. The control groups were those patients who only had primary PCI. And if you look at outcome, also in STEMI, there is a superiority of FFR-guided complete revascularization, both if you perform it within the same hospital admission or when you perform it immediately during the acute primary PCI. So what is the bottom line of FFR and STEMI? In STEMI with multivessel disease, lesions and the non-infarcted lesions, you cannot leave the other lesions just untreated. You have to do something. And both FFR-guided PCI of the other lesions in the acute session, like in Compare Acute, as well as shortly thereafter, like in the pre-multi, improve outcome. And whether you choose for the all-in-one or for the stage procedure within the same admission does not really matter as long as you do it. And this will, of course, also be depending on logistic matters. Is it in the middle of the night or is it in the daytime or not? But anyway, FFR-guided PCI of the remaining lesions is necessary. What do we know about resting indexes like IFR, PDPA at rest? We have seen 2 recent studies in the New England Journal in low-risk populations showing that IFR would be non-inferior to FFR. But there are a few caveats here. The studies were severely underpowered. We know a priori that IFR and FFR yield similar outcome decisions in 80% of the patients. So the power in these studies had to be made by the remaining 20%. And that, of course, weakens any non-inferior design, whereas it would strengthen a superiority design. And the populations had very low risks. In these studies, there were only 0.7 stents per patient, versus, for example, 2 stents in the FAME study, and half of the patients did not have any PCI at all. And there was a large non-inferiority margin, more than 50% of the event rate. So this favors finding non-inferiority beforehand. Except that there was a worrying finding in the meta-analysis of the studies. There was a strong trend to an increased mortality with IFR. The absolute higher mortality with IFR was 1%. And that means, in fact, that you are sacrificing 1 human life in order to avoid a harmless 2-minute adenosine infusion in 100 others. And that is a little bit scaring to me. So we should be careful in extrapolating these results in low-risk populations to an average more complex population, as we see in the present-day cath lab. And moreover, IFR has only been compared to FFR and never proved direct superiority above standard treatment in any study. In conclusion, the superiority of FFR-guided PCI to improve outcome has been directly demonstrated in many randomized controlled trials in almost all clinical and angiographic conditions, in single but also in complex multivessel disease for left mains, proximal LADs, ACS, STEMI, bifurcations, and many others. Thank you for your attention.
Thank you, Nico. Now I'd like to welcome Dr. Lee, who's going to discuss QCA guidance with selective use of IVUS is a reasonable approach in contemporary PCI.
Thank you very much for your kind introductions. So let me briefly talk about QCA guidance with the selective use of IVUS. Here is current recommendation of IVUS in PCI guidance. ACC-AHA recommendation is 2B for coronary stent implantation and 2A for determination of the mechanism of in-stent restenosis. And ESC's recommendation is 2A for coronary stent implantation, so more stronger recommendations compared with the ACC-AHA recommendation, but there are no class 1 indications. So this is current situation of IVUS recommendation in PCI. So let me briefly talk about the 3 topics: why DS failure, trial for PCI guidance, and issuance solutions. This slide shows a pattern and predictor of restenosis after DES implantations. Left side, this is, as you can see, post-intervention minimal lumen diameter is the most powerful predictor of restenosis after DES implantation. So the bigger, the better for prevention of DES restenosis. Right side, this is a type of the DES failure. As everybody knows, mostly focal types, 60%, and 25% diffuse type of DS failure, and 10% total occlusions. As time goes by, more total and less focal type of DSISR. So if you look at focal type ISR, just like second live cases, 2/3 roughly involve instant fusion, and 1/3 involve stent edge fusion. So stent edge problem play also important role in DS failure. What about mechanisms of the DS restenosis? This is my hospital data. As you can see, intimal hyperplasia is the key mechanism of DS restenosis, and followed by stent under expansions. But intimal hyperplasia is not modifiable by intervention technique. The only modifiable factor is correction of stent under expansion. So even bigger, even better for prevention of restenosis. So in summary, post-intervention minimal lumen area, minimal lumen diameter, and edge problem are key predictor of target lesion failure after DS implantations. So achieving a great stent area without edge problem may decrease the risk of target lesion failure after DS implantations. So let me check the trial for PCI guidance. And this slide summarizes 8 randomized trials to compare the impact of IVUS versus angio guidance on clinical outcome after DS implantations. In general, most of the trial favors IVUS guidance. However, if you look at angio-guided groups, there are no specific recommendation or no specific guidance for PCI, and post-dilation was not commonly performed, less than 50%, no single high-pressure dilation or stent implantation or 9%, etc. So let me pick up the largest randomized trial, IVUS XPL randomized clinical trial. In this study, 1,400 patients with diffuse long lesion requiring stented length more than 20 area, randomized 2 group, IVUS guided group versus angio guided group. Prime outcome was target lesion failure. As everybody knows, there was a significant 52% risk reduction of prime outcome in angio guided group compared with the IVUS guided group compared with the angio guided group. So let me check what's the difference between the two groups. If you look at angio-guided groups, stent size and length determined by visual estimation, and post-dilation was only performed if residual diameter stenosis is more than 30% by visual estimations. This is too loose criteria. So the frequency of post-dilations is significantly lower in angio group compared with this IVUS guided group. So smaller MLD and more residual diameter stenosis lead to more higher rate of target lesion failure in angio guided group. I think this is unfair procedure, probably major limitation of previous study, because the key determinant of device failure is not imaging guidance itself, but suboptimal result. So if you look at angio guided group in more detail, PCI are basically guided by visual estimation. And visual estimation often leading to choose undersized stent, and high pressure post-dilation was only performed in less than 50% of patients. So it leads to the stent under expansion. So smaller stent plus stent under expansions is related to a higher rate of target lesion failure in angio-guided group. So I think this, let's move on to issue and solution. So far, visual estimation still remains a traditional technique for PCI guidance. So in routine clinical practice, PCI most commonly rely on visual estimation by an expert. So based on guiding catheter size or balloon size and etc. But as shown in this graph, sizing by visual estimation is highly variable and sometimes not accurate. So which is affected by magnification, zoom 1 or zoom 2, and screen size and physician's condition and etc. So I think we have to go for QCA guidance. This is more objective. So we develop QCA guidance mimicking IVUS guidance to get IVUS-like result, to get IVUS-guided PCI-like result. So design by angio. So design first and then stent it. This is important. And sizing by QCA and finish by 3D. So dilate, dilate, one more dilate. Very aggressive dilation, just like PSP in BBS implantations. So let me start design by angiograms. This is angioplasty, not ibus-plasty, so we can design it according to the finding of angiographic finding. So start with the best angiogram, at least 2 view, and take coronary angiogram at least 20 to 30 seconds after nitroglycerin injection, because peak dilation occurs at 50 seconds after nitro injection. So don't take coronary angiogram immediately after nitro injections before coronary dilations. Landing zone usually shoulder to shoulder, normal to normal, or normal looking area to normal looking area. And don't land at a sharp turning point or bending or milking area. Lesion length is reliably measured by using non-inflated balloon, pre-dilation balloon for short lesion, 15 or 20 millimeter, or by using radio opaque distal tip of the guide wire for long lesions, or either combination of this, so we can easily measure the lesion length and accurately measure the lesion length. And then get the reference vessel diameter by QCAs. I recommend this dynamic QCA. So for very tight lesion or totally occluded lesion, the vessel size is much bigger than much bigger than original size after pre-dilation. So dynamic QCA is important for stent selection or stent deployment. And you have to remember QCA is usually underestimate true vessel size because of angiographic property. So we need this adjustment. So I recommend adjust the target vessel size depending on the QCA measured diameter. Usually we need 5 to 10% corrections, and it exactly matched with IVUS's guided PCI. And finally, finish by first dilations. I think this is the best time to invest because our patient begin to lose lumen area immediately after achieving the peak lumen area by first dilation. So fine edge tunings up to target size, this is very important to avoid stent edge dissection and to avoid stent under expansion. So angiographically it should be smooth and tapered transition. I said this tapering index is within 2-5 millimeter from the stent margin. More than 10%, this is oversizing, so 0 to 10%, probably 3% may be the best. 20%, more than 20% is high risk of edge dissection. And under dilation, so we need additional edge tuning plus 0.2 millimeter. And aggressive in-stent tunings to remove residual diameter stenosis, 0% by visual estimation, less than 10% by QCA, and then we'll get this IVUS-like result, which meet IVUS criteria of successful PCI. So we are doing this guided DS trial to compare QCA-guided DS implantation versus IVUS-guided DS implantation. The goal of this study is not against this IVUS guidance, is to achieve this IVUS-like result using QCA guidance. So in summary, IVUS is definitely helpful to get the best PCI result, but this is expensive and not reimbursed in most countries except Japan. In contrast, the QCA online QCA is available at every cath lab, and this is quick and easy without no additional cost. So to get a QCA, think value first. So I think we have to go for QCA guidance with the provisional use of IVUS. Thank you very much.
Very nice presentation. Thank you. And our final speaker today, Dr. Guagliemi, will be talking about detecting and differentiating plaque erosion versus rupture and whether this matters.
Thank you very much. Here my full disclosure. What is an eroded plaque is not completely clear also to pathologists. Here you have the sum up of one of the most recent consensus documents where they were saying there is no single morphological feature identify typically the endothelium is miss, no association with the degree of stenosis. We still do not really understand the specific plaque feature which distinguish this plaque from the other culprit plaque. What we know now is that Eroded are no rupture plaque, so you are going to make some exclusion. And in this calpary plaque, you have a thrombus. These two characteristics were fused in the major advantage to use one of the most modern technology of imaging. They have a very high resolution distinguishing the calpary plaque between the ones that have rupture, the ones that have no rupture, having a major plus compared to IVUS, being very sensitive to the presence of thrombus. That is one of the key elements of this calpary plaques. Here you have the example of how much these plaques are similar or different. Here you may see one rupture plaque, here you may see one eroded plaque, plus the thrombus deposition. Can we detect eroded plaque in a non-invasive way or by using a different type of modality? This study was combining all the possible imaging modalities in trying to get the differentiation between a rupture plaque, eroded plaque, and patients with a stable angina. As you may see, neither the CT, neither the IVUS can clearly differentiate the three groups of different plaques, while OCT can be based upon multiple different characteristics in these three groups. What about the location of this plaque? Here we are going back to the pathology. You may see that both the rupture plaque and the eroded plaque tend to be fully concentrated in the first few centimeters of the coronary artery. Can we show the same by using intravascular imaging? Here you have Korean data exactly reproducing what you have seen from pathology by using OCT. What about the clinical situation where this plaque can be founded? Here you may see that when you have a patient with a STEMI, despite the fact that eroded plaque represents a significant entity in this clinical spectrum, and calcified nodules are almost absent, they are much more frequently represented as a calpary plaque in N-STEMI compared to the STEMI patients. We did one study to debate if men and women might have the same rate of a plaque eroded as a calpary plaque in STEMI. This series was done in postmenopausal cases, and as you may see, 1/4 of the calpary plaque were clearly represented equally in men and women by the eroded plaque. One very important point is that in 1/4 of this patient, you cannot be very precise in detecting what is the calpary plaque, because still there is a lot of thrombus masking the plaque underneath. These data were reproduced in many multiple studies, showing that the differentiation between eroded plaque and rupture plaque is a little bit more complicated by the fact that in a very significant number of patients, you have massive thrombus precluding the visualization. If you are excluding these patients, and then you are going to compare the outcome of the patients where the plaque, the calpary plaque, was an eroded plaque, or the calpary plaque was a rupture plaque, you may see the bigger difference. And you may see that one of the predictors of the good outcome is to have an eroded plaque as a calpary plaque. Why is a predictor of a good outcome? Here you have a different study comparing eroded plaque versus rupture plaque and a few characteristics. And you may see that when you have an eroded plaque, the risk to end the procedure with a TIMI flow grade lesser than 2 is much lower compared to the rupture plaque, and as well the risk of distal embolization. Why that? Because basically you have less thrombus, basically you have less risky plaque on the way to reach the culprit lesion, so less thin fibrous cap atheroma along the infrarelated artery, and the type of the components is different, less lipidic and more fibrotic. This data was perfectly on order with other data collected in similar population by a different Japanese group, showing that in plaque eroded you have a less lipid content and you have less positive remodeling or you have negative remodeling. And these characteristics were again mimicked by different studies, less lipid, prone to be embolized, and a more negative remodeling. What about the possibility to differentiate the eroded plaque with less variability than by visual estimation? This is one recent study that uses a sophisticated algorithm comparing the site where there is the focal erosion compared to the adjacent zone and compared to the control zone. As you may see, when you have an eroded plaque, you have more protrusion of the tissue, you have more roughness in surface, and you have significant more signal attenuation. And the algorithm might help in having better accuracy. Do we have one single eroded plaque or multiple eroded plaque in the vessel? We might have multiple eroded plaque. This is one of the recent publications showing two different coronary artery in a patient with ACS with a multiple eroded plaque. What about the relationship between spastic reaction and the fact that we have erosion? Here you can see that when you have vasospastic angina, many times without having any rupture plaque, you might have roughness, irregularities, and thrombus deposition on the surface. Why that? Because eroded plaque are a little bit linked with the hemodynamic and the low shear stress. Here you have one recent published example. And here you have the effect of the stenting in eroded plaque. You may see that there is a normalization of the low shear stress, like we are doing every day, without asking if we are treating one eroded or ruptured plaque by using stenting. This was exactly reproduced in Octavia, where we were watching to the response, to the vascular response in eroded and ruptured plaque when they were treated by using stents. And as you may see, there was absolutely no difference between the two, with a very nice and advanced healing. What about the possibility to treat the patients without the stenting and doing with a different medical treatment? There are a few examples reported in the literature. One is Xavier Scaned that was concluded. Our results suggest that in selected patients undergoing primary PCI in women, optimal results as assessed with angio or imaging has been obtained with a thrombus aspiration. Additional stents can be avoided, particularly when the potential benefit conferred by stenting might be outweighed by the anatomical or clinical characteristics. There are new studies. They are trying to promote a possible use of a different approach in these patients. One of these is named eroded, and it was investigated 55 patients having this result at the end of procedure, limited residual stenosis and high TIMI-FRO, and showing that in 1 month of antiplatelet therapy, the vast majority have a significant decrease of the thrombus and reaching the primary endpoint. But still, we are waiting to know the impact on mid- and long-term clinical outcome. So in conclusion, OCT is the most useful imaging modality to characterize plaque with an intact fibrous cap. Thrombus might preclude the visualization of the culprit plaque in about 1/4 of the STEMI patient, less in an end-STEMI ACS. Compared to rupture plaque, eroded plaque has a less lipid component, less positive or dominant negative remodeling, less thin fibrous cap atheroma along the infra-related artery, and better event-free survival. A similar area-assuring vascular response to PCI with the current generation DS has been observed in a rupture as well as in eroded plaque. If conservative pharmacologic treatment guided by systematic imaging might be inappropriate in a larger percentage of plaque with interfibrous cap remains to be proved. Thank you very much.
Thank you very much for that very interesting look at acute infarcts. And that brings us to the end of this session. I think it's been very interesting to watch these cases and hear these lectures. So please enjoy the rest of the meeting.